hepatitis C.
So can you hear me, Maria?
Yes, we can hear you. So
Very
it's
good.
fine. Sorry.
So it's not a recorder. So I'm
No,
live
it's
here. I've been
online.
listening since 6 a.m. in the morning, Central European time. And thank you very much, Dr. Muzabayev, all friends and colleagues for involving me into this really, I have to say, impressive program. I was listening the entire morning, and you have to be congratulated, first of all, for putting all these data together. But to listening to the stories and achievements in all the different countries, which have their own, let's say, issues to be overcome, but that you all are successful in that way, this is really, I have to say, absolutely remarkable. I'm here right now in Hanover. I'm really sorry that I could not travel to Tashkent. We have a serious board meeting this afternoon in Germany where I have to attend. But to come up to to follow the story, I have the privilege to chair a department that is covering liver diseases, gastro, infectious diseases, but also GI oncology, nutrition medicine, and endocrinology. And I think this is important when we talk about viral hepatitis, when we talk about long-term complications. Patients may develop after their infection cancer. They may develop problems of portal hypertension, but they may also suffer from other diseases, including metabolic liver diseases, which may contribute to the remaining risk to develop clinical complications. And this is what I wanted briefly to discuss with you. When you have all done your fantastic job to cure HCV infection, how to continue over there. These are my potential conflicts and biases, but this should not affect this presentation. I'm right now sitting here at Hanover Medical School. You see, we are a quite green city. But again, I have to highlight that we have all disciplines here on campus taking care in the long-term treatment of viral hepatitis. Liver transplantations are performed in this building. Markus Kornberg is heading the infectious disease ward, which is in this building. And we have quite some translational research labs around the campus, which help us to understand liver diseases in more detail. So viral hepatitis this year, and again, this meeting is extremely important because if you include not only B and C, but also A and E, we have to state that there are still many infections with the hepatitis virus every single year. These numbers are high. There are still more than 300 individuals worldwide who carry a hepatitis virus, and the number of deaths we can debate, but it's certainly more than 1 million deaths due to viral hepatitis every year, and therefore we have to work to reduce this dramatic disease burden, what we heard this morning in various presentations. So the question now, you're on track. You try to treat viral hepatitis, but how many patients have actually been treated in the last 10 years when the new DAAs have been introduced? And I want to refer to a paper that is published in the Journal of Hepatology by the Polaris Group, and some of you refer to the Polaris Group. And this is the figure from that paper. You can, until now, about 12.7 million people living with hepatitis C were treated with direct-acting antivirals. And here you see the countries. You heard the story about Pakistan. You're all aware about the story from Egypt, United States. Uzbekistan is right here, as you can see, and there have been more patients being treated in Uzbekistan, for example, than in my country, Germany, and Georgia is on track also, as we heard this morning. But 12.7 million people, Niklas Luhmann and myself, we contributed an editorial. I think the mission is by far not completed. We really have to work to continue treatment. If there are 50, 60 million people worldwide being infected with HCV, and we have to keep in mind that still there are maybe in some countries, in some settings, more new HCV infections than chronic patients that have been cured with the new DAAs. So guys, continue. We all have to work. In my country, the effects of treatments we can see. For example, there has already been 4 or 5 years ago, a remarkable reduction of liver transplantations due to hepatitis C in our country, which is really a success story. And right now, we almost never transplant a patient because of hepatitis C-related liver cirrhosis. We had made some progress in my country that we introduced a population-based screening, a one-time screening for individuals in Germany who are at least 35 years of age. That has been introduced in October 2021, and you can see here that the reported hepatitis C cases per year increased over the last year, almost doubled for hepatitis C. And this is the reason why we had a decline in new treatments in 2019, 2021, and now we treat even more patients than in the years before, which shows that population-based screening, even in our country, is useful and works and identifies cases. But now the question is really, should we only treat chronic hepatitis C? And I think Maria Buti mentioned the issue of persons who inject drugs, who treat and who may not have necessarily chronic hepatitis C, but we need also to treat recently acquired or even acute hepatitis C. And there are quite some studies from around the world that the new treatments are safe, which is not trivial because we're talking about patients who may have liver enzymes of 500 or 1,000 international units per milliliter, and the drugs are safe. Still, there is also in hepatology, there was one article on the GP regimen in recently acquired HCV infection. There are some arguments why we really should treat as early as possible. And I think one of the most important points is that the duration of viremia is shortened by early treatment and thus reducing the risk that these individuals may further transmit HCV. And there are quite some other arguments. You may read this in this editorial that Markus Kornberg and myself contributed to that important paper by Stanislaus Pohl. So, HCV, and we heard this, can be cured in more than 98% of cases. But does this mean that in terms of liver disease, all issues are solved? And the answer is obviously no. We should not forget these patients after HCV cure. And this starts with symptoms. HCV patients may have symptoms like fatigue, impaired overall quality of life. Many of them improve scores. These are data from the German hepatitis C registry, but not all patients. And you can see here 1/3 of the patients, 1/4, 1/3 of the patients still have reduced components in these SF36 scores, both for physical as well as for mental scores. I think this is something we should not forget. And therefore, we tried, everybody's talking about long COVID after SARS-CoV-2 infection, but HCV may also induce imprints in the immune system, which we call long hep C. For the last 10 years, we've been publishing on this, both on cytokine markers. It was our first paper in 2016. And since then, we studied different immune cells, mate cells, NK cells, proteome signatures. And in almost every paper, we could show that some imprints of HCV induced in the immune system, they do not completely normalize, and we are continuing. I don't show you this in detail, but even 5 years after HCV cure, if you have a look at NK cells, they still look different as compared to healthy controls. So in Germany, we have the German hepatitis C registry, which is a quite nice story over the last 10 years. We started in 2014. We applied all the different drugs. We had different phases, and we have documented now almost 15,000 therapies in this hepatitis C registry with quite some publications. This is data from last year. And what I want to highlight, even though we cured many, many, many patients, you see also here that if a patient starts off with liver cirrhosis, you still have more than 20% of patients who develop clinical complications despite HCV cure. So the question is how to identify these patients who are still at risk after HCV cure. And there have been many papers published in the last 2, 3, 4 years, different scores, fibrosis, F3, remaining risk, cirrhosis. What shall we do? Because we are treating so many patients, if we still have to cure 40, 50 million patients, we cannot follow up them every 3 months in our clinics. And therefore, we mark us how to identify these patients who are really at risk to guide risk stratification. And obviously, we're talking about non-invasive markers, liver stiffness measurements, if available, is really useful. This is a huge study from European countries. More than 2,000 patients were followed for up to 6 years. And then the authors, let's say, investigated whether the most recent measurement of liver stiffness or the relative decline is more important to predict long-term outcome. And the short message is that the post-treatment liver stiffness measurements rather than dynamics should guide risk stratification. And obviously, if you have a liver stiffness above 20, as we all know, this is not good. And below 10, I think these patients we can discharge from our surveillance. They have a negligible risk to develop clinical complications. While if you have still a gray zone here between 10 and 19, and we have to discuss how to follow these patients. And this has been confirmed by a variety of other studies. Again, I want to highlight here a J. Hepatol paper from France, where Dr. Nahun investigated FIB-4 scores, APRI scores. He investigated a large number of values and changes over time. And again, the same message that the most recent NIT current value really predicts HCCs rather than the NIT slope before treatment as compared to long-term treatment. And you can see here that over time, the risk is constantly increasing. So there's no plateau. We cannot leave these patients alone, both in terms of HCC risk, which is the red line, as well as death or transplantation, decompensation events. You can see here this risk is constantly developing. There's no plateau. We cannot leave our patients alone. And FIB-4 scores, APRI scores are useful if liver stiffness measurement is not available. So can we be even more clever? Let's say we are living in the year 2025. We have artificial intelligence. And can we not just a computer tell me if I need to see my patients at what time interval? And people are working on that one. It's not ready to use for clinical routine care, but just to highlight that in the Journal of Hepatology, we just published a paper where an AI safe C-score based on artificial intelligence was developed, and it was superior to a variety of other markers, FIB-4, APRI, liver stiffness measurement, etc., etc. So it was all compared, and you can really nicely see that you have high and low risk patients. There is the scores available on the web. You may check whether this is useful for you. I don't think that in my country it will be used to a large scale, but it shows you that this is in principle possible. What we also have to keep in mind is that if a patient cures hepatitis C, they can still suffer from other liver diseases, and obviously metabolic dysfunction associated steatotic liver disease is as an important contributor to post-SVR HCC risk, which seems to be trivial, but we see data in this case here from Taiwan, PJ Chen and Dr. Kao contributed this paper to our journal. And again, here, the MASLD patients have a much higher risk to develop HCC than patients without mast cell. They did different models where they calculate the hazard ratio, and it doubles or even triples the risk for HCC. So treat the metabolic dysfunction, and we are looking forward to the talk by Grace Wang later, who will highlight this disease in more detail. This is data from the German hepatitis C registry, which we just presented at EASL. And again, overweight seems to be more important than low level of alcohol consumption. So you can see here the survival functions in the long term. And these two curves here, the blue and the green ones, are those guys who are obese, either with alcohol or without alcohol consumption. So they take a poor outcome, while the lean persons have a much better outcome. I don't want to comment on the fact that, at least in this analysis, a low level of alcohol seems to be beneficial. You may remind this when you have the faculty meeting or the dinner meeting of the Congress tonight. The last point I want to highlight is, if a patient starts off with decompensation and if they recompensate with HCV therapy, they are still at a high risk to develop clinical complications, even though the outcome is improved. So the risk is reduced by recompensation, but you can see here this group, these are just compensated cirrhotic patients, the risk for developing endpoints. These are those guys who are decompensated, so very high mortality, high risk for HCC and liver-related complications. And here you can see the group that started off with decompensation, but then recompensated, and you can still see higher risk for mortality. HCC risk remains high and is not reduced, as you can see here, and these are the liver-related events. So don't leave these patients alone. And we may even study, and this is again our research here, where we try to understand immune surveillance role post-SVR. And if we can look at the immune system and then say this patient is developing HCC, this is not. I don't have the time to describe this in detail. I'm going to refer to that paper, but immunity really plays a role. We need to understand this better, why some patients develop HCC and others do not. So my summary is basically from the follow-up after HCV cure. I think HCV-induced imprints on the immune system persist after SVR. The immune system does not normalize, and this may lead to persistence of symptoms. And we should not only talk about long COVID, but long Hep C is an issue. So what to do in the follow-up? We all agree that liver-related complications may occur even after HCV cure. There is a high risk, in particular in patients with recompensated cirrhosis, and MASLD is a major risk factor for post-SVR HCCs. And we need to guide HCC screening based on simple parameters, and we should use in non-invasive tests, APRI, etc. They may be useful, but rather rely on the most recent and current NITs than on NIT changes over time. They have been shown in different papers not to be that useful to guide HCC screening. And if we use in future AI tools, will be interesting. I like this idea as a support, but we should not forget that we have a patient sitting in front of us, talk to the patients, and not that the computer is telling us alone how to deal with these patients. And the last point, you always know, I always show that coffee is good for the liver, and that the coffee consumption is a dose-dependent effect to improve the outcome and to reduce the risk for HCCs. But in addition, based on a paper published in the Journal of Hepatology, we should also have a sour taste to improve liver inflammation. You will not forget this. This is a super cool paper published from China in the Journal of Hepatology. The short message is that nerves in the liver produce a substance called TAFA2, which is binding to CCR2 and driving liver inflammation. So the nerves produce a bad molecule, and the release of this molecule is regulated by tasting sour signaling. This is interesting. If we would have time, I could discuss with you this paper, 6 figures, A to K, very nice mouse models, really confirming that sour neuronal signaling attenuates liver inflammation. They really proved this in mouse models. Now you may argue, why do I tell about this? What's about human beings? They even did a clinical trial in patients after human hepatectomy, where some of them received citric acid and control group, and you can see here that liver enzymes are really reduced, which I think is quite interesting. So my last slide from now on is not only showing coffee, but coffee and lemon. And thank you very much for listening, and happy to participate in the discussion.